Up next, we have a dynamic and thought-provoking pros and cons debate. The topic of discussion is general anesthesia versus regional anesthesia for laparoscopic procedures. Speaking for general anesthesia, we have Dr. Joan Chirayath, Associate Professor and Clinical Lead for the Critical Care Unit at Amala Medical College, Thrissur. He has worked as a consultant in Royal Shrewsbury Hospital, UK. He holds the prestigious MRCA from UK, FCRCSI from Ireland, and CCT from UK. His areas of interest include critical care. Presenting the case of regional anesthesia, we have Dr. Anju Mariyam Jacob, Professor at Government Medical College, Trivandrum. She is AHA certified ACLS trainer. She has completed her advanced course in medical education, was a coordinator for MEU Government Medical College, Thrissur, and was transplant recruitment manager for Thrissur.
So I'm just waiting for the screen. Good afternoon. A debate. Should I roll up my sleeves? Probably I shouldn't. I know Dr. Anju very well. So coming on to the topic, along with me I bring regards from Amala Medical College, Thrissur. So general anesthesia for laparoscopic surgeries. In the context of this debate, thank you very much organizers for inviting me across to do this talk. And a disclosure, both myself and Dr. Anju haven't spoken about this topic. We haven't discussed any of the slides. So on that, first thing, take out your brochures, look at the fine print. In the fine print, the topic was GA for laparoscopic surgeries. And so it is not about a quick look laparoscopy, and it is not of having RA as an adjuvant to GA. It is cases to be done under RA or GA, laparoscopic surgeries. The first thing, primum non nocere. It's part of your Hippocrates oath. You all must follow it. That means first do no harm. So it is always a risk versus benefit, and you shouldn't be doing any harm. Why a crusade against GA in this context? Is it just because it's the gold standard and you want to do something differently? Is it just to prove a point? Truly, is there any real evidence out there to substantiate that regionals are better than GA for laparoscopic surgeries? We'll come to that. Now just think about, what is the purpose of anesthesia? It is to make surgery safe. It is to make the surgeons' work easier. Surgeons are not our enemies. We survive because of them and they survive because of us. So let's make their work easier. And are these really happening by a laparoscopic surgery being done under a regional? I really doubt it. General anesthesia. Now you are saying that you want to do it under regional. So general anesthesia, are we really scared about it? Aren't we masters of that art? Aren't we called the medical magicians? Are we just being lazy by saying that, okay, we'll do a spinal and have a cup of coffee? Are we really worried about the cost? How much will the cost be different? 100 rupees versus maybe ₹1,00,000 for the surgery. Are we really worried about those rare or mild side effects of a general anesthetic in most of the cases, in a normal case? So let's compare the side effects. The side effects of an ETT in a normal case are probably a little bit of sore throat, minor airway injuries. Are there really big issues to compromise on safety? What about issues of not having an ETT, doing it under a regional, improper ventilation, basal atelectasis, a shunt because of VQ mismatch? The patient can become restless. Then what do? It might be because of difficulty in breathing. It might be because of a shoulder tip pain, and then you give some sedatives to that patient whose abdomen is distended. And then, how many times has your surgery went on perfectly, laparoscopic surgery? Sometimes it's not straightforward. And then what do? What are my concerns in a laparoscopic surgery? My concerns are the surgeon, the experience varies, the time periods vary. So that's my first concern. The position. The head might be touching the floor because you have to make it comfortable for the surgeon. And then how do you go about it? The length of the surgery, somebody might take 1 hour, somebody might take 10 hours. The surgery might turn out to be complex. The patient can be of any size. The intra-abdominal pressures, yes, we know theoretically it should be low and then the surgeon will say, can I increase it a little bit more and more and more? And if it's a regional, just imagine the situation. And one serious complication should not leave a stain in my mind forever, that it's happened because of me. So what do our textbooks say? Miller, Morgan, they don't mention about laparoscopic surgeries much, surprised. Barash writes about it, and this is just, it's a cut and paste from Barash. And the first sentence is, general anesthesia with endotracheal intubation, muscle relaxation, controlled mechanical ventilation remains the preferred anesthetic technique for laparoscopic surgery. What does UpToDate say? Again, the best evidence out there. What do they do in UpToDate is they give that topic to an expert, and that expert collects all the evidence and puts it in UpToDate. The latest UpToDate, this article goes up to March 2025, and that person has written, in most cases, we perform general anesthesia for laparoscopy and robotic surgery. In the next paragraph, they've written, others use. So we don't use, others use, because there is some evidence here and there. We'll come to that. NYSORA. What is NYSORA? New York Society of Regional Anesthesia. And you just do a Google search on NYSORA, and you'll get this. What does it say? The highlighted part in red, GA with controlled ventilation is the most acceptable technique. They've written about RA only in post-op pain management. So NYSORA itself has admitted that GA is how you should do a laparoscopic surgery. Striking heading. Laparoscopic cholecystectomy under spinal anesthesia, a study of 3,492. I was surprised. I thought I'll have to call them up and say that I won't do this topic. It was such a big number. And it came in 2009. This article, you'll get only an abstract. So I digged in through my library, I got the article. And I did a critical analysis of that article. It's a single sender, single surgeon, because the surgeon is the first author. Anesthetic article, surgeon is the first author. So it might be his idea. Retrospective study over 12 years. So it is not a study. It is a practice newsletter. Whatever they have been doing, whatever he has been doing, he's made it into an article and published it. None of the research criteria were satisfied because the technique itself had changed. They had used xylocaine earlier. When I was a PG, we used to use xylocaine, 5% xylocaine for intrathecal. And then later on, they've changed to heavy bupivacaine. So the technique has changed. The monitoring standards have changed. So many things have changed. The pressures, he might be an expert. The pressures he had was 8 to 10 millimeters of mercury. And he finished the surgery within 30 minutes. That's what's written. But how many of them will finish within 30 minutes? Notably, hypotension was there in 20%. 20% of 3,492. That means around 700 patients had hypotension. Neck and shoulder tip pain in around 10% of that will be around 400 odd patients. Postural headache, surprisingly, postural headache, which persisted for 2.6 days in 5.9%, around 6% patients. So around 200 patients had persistent post-dural puncture headache. Why? Might be because of the abdominal pressures, which has maybe increased the CSF leak. And one other surprising bit I noted was In the methodology, the level written was L12, only one level, L12. So nowadays there's so much of talk about thoracic epidurals. Where does our spinal cord end? In an adult, it ends at the lower border of L1 or upper border of L2. So that means this must be the first article on thoracic epidurals actually, and with that much number, because he started this study must have started in 1999. So this must be, he shouldn't be publishing this article for this. He should be publishing this article for doing it with the intrathecal at the spinal cord level. Okay, so then I thought I'll search a little bit more. Is there any other, heroic things being done? Operative gynecological surgery under conscious sedation, around 45 patients I think, they've done it under conscious sedation, procedures. And they have found, again, the inference is that it is good, but they've actually, when you look into it, they've given a lot of ketamine and that and this and this. So I don't know whether it is at regional alone, something mixed with it. So isn't there a chance of a bias? Could the complications with regionals actually be underreported? Why are there no multi-center studies? If it's so good, why can't they do a proper multi-center study or a proper randomized control study? All the comparative studies mention proper selection of patients. Why? You have to select patients properly for doing this procedure. Then why do it? Think about the ifs if a regional is going to be used for this surgery. If not obese, if no airway issues, if not expecting any regurgitation, if not pregnant, if not appendectomy, because appendectomy supposedly can cause dysmotility. So if there are so many ifs to be ruled out, then why challenge the gold standard? Now, what are my worries in GA? Sometimes if the patient has a cardiac issue, suppose somebody is coming for a finger injury or a hand injury, and they have a cardiac injury or they have a respiratory problem, then a block, yes, there is a point. But can a central neuraxial block or any field block in that context be a solution to the cardiac or respiratory compromised cases when I am doing a laparoscopic surgery? No. So because the abdomen is distended, you cannot take a chance. So then why do you want to use it? What about medico-legally? You have done a case under regional and then there's a problem. When all the evidence out there, all the textbooks that we have say the gold standard is endotracheal intubation, the rest are just comparable to, could be used, proper patient selection. So what is the judge going to think? It's up to your imaginations. So that's how I would be if that happens. I would like to be known as a safe anesthetist rather than a dashing one who takes unnecessary chances. As an anesthetist or a teacher who practices evidence-based medicine based on solid evidence rather than one paper wonders. As an anesthetist whose patients are safe and sound rather than, even if rare, ending up with a complication due to me. As an anesthetist who's not only bothered about the number of research publications, just for a publication, don't do something naughty. After all, it's a human being who's put their whole faith on us, the medical magicians, thinking that he'll come out of it. My thoughts, to me, it's like trying to change the 3-point seatbelt technology. Volvo car, Niels Bohlin actually is the person who brought the seatbelt technology in 1959. Till now, that hasn't been changed. And he could have been a millionaire, he didn't take a patent out of it. So this is something like that. So trying to challenge it as of now is something like that. So substitutes claiming to be as good as would keep on coming, but none of them till now have the safety profile history of our time-tested endotracheal tube in laparoscopic surgeries. Again, primum non nocere, be safe first, just tube it, and the laryngoscope is the tool of this trade. Put a tube in and sit and have a nice cup of coffee, not the other way around. Thank you very much.
Now, I kindly invite Dr. Anju onto the stage.
Thank you very much.
Conference, the two-day conference, the enthusiastic team of Dr. Mupin's Medical College, Akama Devi Madam and Dr. Arati for this invite, yesterday's as well as today's. Dr. Joe has eloquently proposed for general anesthesia and he has made my task very tough. Can I just have a show of hands who have done regional anesthesia for laparoscopic surgeries? Akka Mahadevi Madam has put up a hand. Yes, I see a few hands at the back. Thank you very much. I think quite a few of these people are postgraduates. So let's take it in that sense. Okay. So let me begin my talk by tweaking the quote from Hamlet. To do or not to do, that is the question. I hope I'll be able to clear a bit of the doubts that are there in your mind at the end of my talk and get a few more people to team regional anesthesia for laparoscopic surgeries. Had today been the 17th of August 1898, the next day after August Bias successfully did his first spinal anesthesia, today's pro-con session would have been on GA versus spinal anesthesia, and we would have been going on and on about it as to how safe spinal anesthesia was. This is so with regards to any new thing that comes in the medical field. We definitely have put up our tribulations and we are doubtful regarding its safety features. But definitely we know that we have certain criteria for which we give regional anesthesia and certain criteria for which we give general anesthesia. We know that we cannot give spinal anesthesia for a thyroid surgery. In the same way, we may have some inclusion criteria for giving regional anesthesia in laparoscopic surgery. But let me remind you that for any new procedure that comes to being in anesthesia, whether it is a regional block or a spinal anesthesia or an epidural, whatever be it, the fail-safe for all these techniques is general anesthesia. In case you come across a complication or in case you come across a patchy procedure, maybe a patchy block, whatever, your final fail-safe is general anesthesia. But there are certain advantages to regional anesthesia. Now, I am giving you a blanketed set of advantages. There are definitely advantages for spinal anesthesia, for combined spinal epidural and for epidural alone and even for regional tap blocks. So, coming to the advantages of regional anesthesia over spinal anesthesia, one, you definitely have a quick recovery. You want people to be discharged fast from your OT and so that your next case can start. It has a good advantage of giving effective post-operative analgesia, especially if you have put adjuncts along with your spinal drugs or if you have put an epidural along with it. And here we do not have any airway manipulation and we have a shorter post-operative stay. Of course, Dr. Joe said there's not much of a cost effectiveness. Let's take it from the point of view of a patient coming to you in a government hospital. Definitely laparoscopy is very expensive in a private hospital, but in a government hospital we have to buy drugs or make the patient buy drugs sometimes if it's not available. So if it is a spinal anesthesia, we just have to make the patient buy one single drug. While if it's a general anesthesia, we'll have to make the patient buy a lot of drugs and the surgery is free except for a few things they might have to buy along with that. So definitely it's much more cost effective when compared to general anesthesia. And we have a lesser incidence of post-operative nausea, vomiting. This is proven all over with multiple studies which have come out and which has proved that spinal anesthesia, regional anesthesia has a reduced incidence of post-operative nausea and vomiting. And when did laparoscopic surgery start getting done under regional anesthesia? It was when we had extremely sick patients. As a matter of fact, I have given regional anesthesia for laparoscopy only for sick patients. Most of the normal patients we've given under general anesthesia. It's extremely sick patients like CKD patients. Yesterday's case discussion, if you had heard, you would have seen that point was discussed here. CKD patients, ischemic heart disease patients, patients with severe COPD who cannot undergo, who have a great risk. Definitely your risk versus benefit have to be measured here also. So the risks are more for a general anesthesia in such cases, and that is why regional anesthesia started evolving with laparoscopic surgeries. So why did laparoscopic surgery come into being? That is, there were so many benefits for the minimal access technique. As a matter of fact, open techniques are going obsolete nowadays, and most of your surgeries are being done under laparoscopic surgery now, because it's got a lot of benefits which are less pain, early mobilization, minimal scarring and shorter hospital stay. And basically these are turning out to be outpatient surgeries. So what happens? In case, definitely we have excellent drugs in general anesthesia nowadays, like excellent drugs with excellent profiles like your remifentanil, etomidate, propofol, Sevo, desflurane, all that have got excellent profiles for an excellent recovery. But you may end up, we can definitely vouch as anesthesiologists giving large number of cases, we do have complications and side effects that occur, consequences that occur as a result of general anesthesia. And if you have a patient who can undergo a laparoscopic surgery under regional, why not reduce these side effects of general anesthesia, which may negate the advantages of laparoscopic surgery. Now, while I was doing a literature search on laparoscopic surgery under regional anesthesia, I hit on 66,500 results in just 14 seconds, not 14 seconds, 0.14 seconds, less than 1 second. Now, this was an article which came in 2013 in the Journal of Anesthesia, which I found rather amusing. Can you just look, they used to give regional anesthesia for laparoscopic surgeries for very sick patients who were too sick for general anesthesia. And they found that regional anesthesia could also be a reasonable choice in certain settings, and that's what I have to say too. Again, another article in the North American Clinics of Anesthesiology in 2001 said that the scope of regional anesthesia depends on the creativeness of the surgeons and anesthesiologists and patient acceptance. Now, let me harp on the study which Dr. Joe had quoted earlier on. His study was published in 2009, while this study by the same set of surgeons was published in 2008. His study had only laparoscopic cholecystectomy which was taken into consideration, while this study was a retrospective study for 11 years on data from 1995 to 2006. That is 11 years. And they said, see, remember, laparoscopic cholecystectomy was first done in 1985. And within 10 years, this college in Jhansi, UP started performing regional anesthesia for laparoscopic surgery. Within 10 years. And they did a multiple array of surgeries under laparoscopy, out of which 2,992 were lap cholecystectomies. Lap appendicectomies were 614, diagnostic lap was around 401, and lap urethral-lithotomy with nephrolithotomy was 192, while other lap surgeries like lap lumbar sympathectomy, hernia repair and duodenal perforation included the rest of the number. Now, there were around 421 lap surgeries done under general anesthesia. Who was made to be given general anesthesia? Those were pediatric patients less than 10 years of age and those people who refused to undergo laparoscopic surgery under regional anesthesia. So, here's a set of the complications that they have put up. Now, what Dr. Joe said was correct. They did spinal anesthesia with 5% lignocaine and 5% lignocaine heavy, which we've been used to when we began our practice in anesthesia. And as postgraduates as well as earlier practitioners of anesthesia, we know, those of us who have used lignocaine, we know that hypotension is the complication that you first see, and it's extremes of hypotension that you see as soon as you've given your spinal. Even before you turn the patient straight to supine position, you will see that the patient is severely hypotensive. You have to literally run. Actually, that is what made us fast acting anesthesiologists, treating hypotension for spinal anesthesia under lignocaine 5%. Now, here also they have mentioned beyond the abdominal pain, the next complication that they mentioned was hypotension. I think this would have been an add-on to the lignocaine anesthesia that they had given for their spinals. But one thing that you should note is that lignocaine anesthesia for spinal finishes off, it's like a switch on, switch off mechanism. It just finishes off in 30 minutes. Otherwise, you had to give adrenaline flushes and all along with that, to prolong it for another maybe 15 to 20 minutes. So, maybe that would have been the cause for this increased level of hypotension that is seen with spinal anesthesia here. Followed by neck pain, which was the next complication which was seen at 12.29%. But they all had pain, abdominal pain, which were treated with injectable analgesics at 35.59%. Other complications that were associated were urinary retention and headache. So, what are your concerns for regional anesthesia? Basically 3 concerns: hypotension, shoulder pain and changes in respiratory mechanics. So, what is the cause of hypotension in laparoscopic surgery? It is your pneumoperitoneum causing inferior vena cava compression, leading on to a decreased venous return and cardiac output, causing hypotension. And this is usually seen with intra-abdominal pressures of greater than 15 millimeters of mercury. If the IAP is kept below 15 millimeters of mercury, it's much better for the patient hemodynamically, because there is better emptying of the splanchnic vessels, leading on to an increase in the venous return with no hypotension. Therefore, ideally, a laparoscopic surgery should keep an IAP between 8 to 10 millimeters of mercury. Other measures could be employed to overcome hypotension. Hypotension is not something that we are not used to as anesthesiologists. By decreasing the head tilt, adequate co-loading, liberal use of vasopressors and the use of segmental spinal in the upper abdominal surgeries. Now, coming to this study by Imbelloni, what he did to elevate shoulder pain was he instilled local anesthetic into the abdominal cavity as soon as the trocar was introduced. Now, this is not anything new. More than 35 years have passed since laparoscopic sterilization is being done by our counterparts in obstetrics and gynecology, where as soon as the needle is put in, they instill a large amount of local anesthetic, then they just shake the anterior abdominal wall, wait for some time and then start producing pneumoperitoneum. And they have been very successful in doing it under local anesthesia with severe head down tilt. And people, I know so, because that is practiced in all the PHCs around Kerala. And so that is one method of elevating shoulder. None of them complain of shoulder pain. Now again, another study by Simoyanis, he instilled normal saline into the subhepatic region first, and at the end of the laparoscopic surgery, once there was a deflation of the abdomen, he removed that normal saline and instilled 0.125% bupivacaine under the right diaphragmatic region, which was very helpful in removing the shoulder pain. Also, the trocar site was instilled with local anesthetic. Also, you can use bolus doses of injection fentanyl to overcome this. So, a point in favor of regional. Under regional anesthesia, shoulder pain can be identified intraoperatively and adequately treated, as opposed to GA, where the patient complains of shoulder pain in the postoperative period, by which time your abdomen would have been closed for any intraperitoneal interventions which you could have done if the patient was under regional anesthesia. Now, coming to the respiratory mechanics, we know that this increase in IAP produces a cephalad shift of the diaphragm, leading to basal atelectasis with increased intraperitoneal shunting and increased airway pressures. So, again, keeping your IAP between 8 and 10 removes all this. You have a spontaneously breathing patient who can compensate for whatever mechanical changes that occur, and there are reports showing that there is no significant change in respiratory mechanics. Now let me harp upon my previous study by Collins in the North American clinics, where he says that it is the creativeness of the surgeons and anesthesiologists and patient acceptance that you should take into consideration before subjecting a patient to regional anesthesia under laparoscopic surgery. So we have certain inclusion criteria. What is that? You need a cooperative patient. They must be kept comfortable, and they should be told the consequences. And you know, all of you are dealing with a lot of patients. You know which type of patients may not accept this regional technique. But again, you have anti-anxiety drugs that can be given. Then of course, the most important thing is an experienced surgeon who will be able to do laparoscopic surgery under low abdominal pressures with minimal manipulation, who is quick and produces no complications, and who does not require extremes of tilt. But unfortunately, every new budding surgeon here nowadays are laparoscopic surgeons, and they are on the steep slope of the learning curve, and only very few of the experienced surgeons are there at the plateau. So I think the number of people who can achieve this, or the prowess to do a laparoscopic surgery with lesser inflation of the abdomen, are very few. So please choose your surgeon correctly if you are attempting a regional block for laparoscopic surgery. So, and then finally, the final thing is a creative anesthesiologist who is well versed and who knows your patient as well as your surgeon very well. Now let me just sum up. Regional anesthesia provides better lap surgical conditions due to profound muscle relaxation, much better than general anesthesia, and a shorter recovery phase. Now, it may require a T3 block for lap cholecystectomy, which can be easily achieved by segmental spinal anesthesia. Extremely good analgesic profile when compared to general anesthesia. Shoulder pain can be identified intraoperatively and adequately treated before the patient is shifted out, and the benefits of minimal access surgery are augmented by a regional technique for laparoscopic surgery. I rest my case. Thank you very much.
Thank you, ma'am. Next, we have a countering session. First, we have Dr. Joe on the stage.
This is the pointer. I'm not taking the mic.
Anesthesiologist. That's what Dr. Anju said. Do you want to be creative or do you want to be safe first? The article that she said, my version was the same person, 3 or 4 times they have published an article based on the same cases. So every 5 years or something like that, they have published an article. And that is the one, the last one was the 12-year one. And that is where they have put in the needle without knowing between L1 and L2. Okay. Now, I've laid down my facts with evidence. It's up to you to be safe or not. I'll give you an idea. If you make a local anesthetic which has 0 sympathetic block, 100% sensory block, and a bit of motor block, yes, the patient shouldn't kick the surgeon out, then maybe you will get a Nobel Prize and you will become a millionaire. That time, I'll start thinking about regional anesthesia for laparoscopic surgeries. Thank you.
On to you, ma'am.
Let me just harp on the point about creative anesthesiologists. Now, if you are not a creative anesthesiologist, anesthesia would not have advanced to this place with multiple modalities for giving anesthesia today. Unless there was a creative anesthesiologist somewhere who thought about spinal anesthesia or a regional block or an ultrasound machine to give that block, nothing would have happened, and we would still have been tubing every patient that came onto our table. So that is one point for a regional anesthesia. I think we have to evolve with the time. Now, regarding this article, it was not only this article, this was the biggest study that was conducted. There were many articles that were there. Now, I would like to get a share of the opinion of Akka Mahadevi madam, who has given regional block, as well as Dr. Sunil Rajan at the back. They are practicing that in Amrita, regional anesthesia for laparoscopic surgeries. Madam, a word from you.
Uh, if I have to express my experience with regional anesthesia as you said, it was most of the times the high-risk patients, patients with COPD, IHD, for whom I was very afraid to give general anesthesia. But the point to be stressed upon, underlined 3 times, is my surgeon was excellent, who would finish his lap colis in half an hour. And of course, during the insertion of, while creating pneumoperitoneum, there used to be shoulder pain, for which I used to give an analgesic dose of ketamine that used to take care of the pain. Otherwise, as a team, we were excellent. That's all.
So the creative anesthesiologist should keep that also in mind. Thank you very much, madam. Sure.
Actually, I always give general anesthesia for laparoscopy. Only once in my life I've given a regional. Okay, I was stuck. It was soon after my PG, and I gave a GA for a diagnostic lab, and patient went into severe bronchospasm. Went into hypotension, and somehow I managed and put the tube out, managed, and patient was stable. But the surgeon insisted that he want the case to be done on that day itself. So finally, I was forced to give a spinal. I made the patient lie supine for some time, then gave a head down tilt, asked the patient to take deep breath in voluntarily, and I managed. But I usually give always general anesthesia only. Only once I gave spinal.
So I think all of us here give regional anesthesia for high-risk cases. But there are institutes, especially in Thrissur, there are a few private hospitals. I know where one of our colleagues, he practices regional anesthesia for all laparoscopic surgeries, and even for children above 10 years for appendicectomy. Actually, if he was present today, he would have really got up and this topic is hot for him, and he would have got up and really defended this topic much better than me, I think.
One more point I want to say. See, and after that, what I started practicing is give spinal and GA. So that, during laparoscopy, invariably you have tachy, hypertension, and more requirement of analgesics. That will be taken care of beautifully. The hemodynamics will be maintained very well with the combination of that.
That is what I also used to do, madam. Either an epidural or a slow dose spinal with opioid. It really takes care of the tachycardia along with general anesthesia. Because it is a stretch of the muscles, extreme stretch, especially due to the high IAP that causes the severe tachycardia. That is what is propounded, and that is taken care of by your spinal anesthesia. So thank you very much. I think we can close the session. Or do
Thank you, ma'am.
Thank you, Dr. Anju, for countering me.
Good afternoon, all. As Joe sir told, the standard textbook says general anesthesia, but now there is lot of talk happening in segmental spinals and especially isobaric spinals, especially in India. I think Naresh Paliwal, sir, he is coming up with so many articles doing laparoscopic surgeries under thoracic spinals. Joe sir was emphasizing on L1. I'm not against GA, because always it is, if it's no contraindication for GA, go ahead with GA. But if you don't risk the patient's life, always you can go with spinals. We are doing it under thoracic spinals. And another thing, since we don't have spinal catheters, otherwise, especially in European countries, they do laparoscopic abdominal surgeries under continuous spinal also.
Thank you, ma'am. Thank you, sir. Now, I kindly invite Dr. Aruna ma'am onto the stage to felicitate Dr. Joe. I also invite Dr. Akka Mahadevi onto the stage to felicitate Dr. Anju.